Hello everyone and welcome to this week's Instagram Live. Hello everyone, my name is Nicole. I'm the social media coordinator here at LTC. Today's Instagram Live will be about hormone therapy. So Mary Burke, the head hormone clinician, will join us today. And we're going to go through some questions that you guys sent in earlier, and then we're going to look at the comments as well. So if you do have any questions, just leave them in the comments and we can have a look later. So I'm just checking if Mary is free. I haven't done an Instagram Live in like ages, so I'm a bit rusty, but I'm just waiting for Mary to join us and then we can get started. I can't see the request. So just send Mary the request, so hopefully she will join us shortly.
Good morning. Hello,
Mary. Hi, how are you?
I'm good, Nicole. How are you?
I'm very good, thank you. I just had my vaccine yesterday, so my arm is a bit sore today.
Oh,
But it's fine. That's the only thing.
Oh, nice one. Well done, you.
Yeah.
Bloomin' heck. I've had both mine, thank goodness.
Oh, really?
Yeah, I'm glad. It just makes it easier for work and for travel and for just keeping everyone safe. So yeah, it's fantastic. It's great. Thank God it's Friday, everyone, and thank you all for joining us. I'm probably just going to do a runner just after 3:30. I won't be doing an hour today because I have to post my prescriptions to my patients and I'm meeting a few friends later on. So I've got a bit of a journey before I do that. And we'll be abiding by all the regulations and rules, but it's just so lovely to get out. Really is. So yeah, oh God, it is. It is so nice.
It seems like we're going back to normal slowly.
Yes, yeah. And that's
so Mary, let's get started. So we got sent in some questions. So I'm going to start with the first one, which is a bit generic, and I think it's a good question to start with. So what are the pros and cons of testosterone and libido?
Okay, so well, at the London Transgender Clinic, we like to start you on Testogel, because with Testogel, you're getting a daily dose. Probably 98% of our patients will get excellent levels and they'll transition very well on it. And the thing is, sometimes, you know, if you have a history of any mental health issues and your moods are a little unstable, if you start on gel, it means that what we can do is we can gradually introduce it because it's a very powerful hormone. So you can start on just half a dose for the first 2 weeks, see how you feel. If everything is okay, then you can go on to the full dose. which is 2 compressions a day, really, or 2 pumps, whichever way you like to put it. And it works very well. A lot of patients come back at 6 months and they say, you know what, I'm really happy with it. I've got a daily routine, and it works really well. And the other advantage too is that there's not a lot of blood testing that has to be done initially in those first, for the first 6 months. Once your initial blood profile is normal and everything is good, then, whereas say if we move on to Sustanon is the short-acting injection. And the short-acting injection, if you were starting it, I usually start about 1 every 3 weeks. But the thing about this is, as soon as you have that injection, your testosterone level now we're aiming for a testosterone level high teens, early 20s, okay? But literally within minutes of having the injection, your testosterone level, I have a few patients have levels in the 60s and the 70s and the 80s, because they've made the mistake of having the blood taken directly after having the injection. And you've got to have blood tests done, in 3 weeks' time, in 6 weeks' time, in 9 weeks' time. And it's very difficult getting access to your GP, organizing all that. If it can be a little difficult. And also, accessing, if you don't want to give your own injections, having to make appointments at the clinic. One of my patients goes in every 2 weeks, and it's a lot. So generally what we prefer to do is, and because it tends to be easier for the patients in many ways, is to start them on Testosterone, see how they do, and then at 6 months have a discussion. And I like the long-acting testosterone libido, because it means that, I have some patients who are on it every 10 to 12 weeks. I have other patients who are on it every 18 to 23 weeks. So it means that you could end up having 3-4 injections a year. And that's a lot easier than having to self-inject every 2 to 3 weeks. And once everything settles, we monitor for the first 18 months to 2 years, because there's always a risk we find with libido because testosterone stimulates your bone marrow to produce more red blood cells. There can be a risk with that. So, and of course we always advise, not to smoke and to drink plenty of fluids and, all of that. But there are pros and cons, but what we try and do is, figure out with the patient what's going to work best for them, and then work with them to try and, provide the medication as safe as we possibly can.
Perfect. So another question is, can I do libido shots myself, or does it have to be a nurse?
No, it's a tricky one. It has to be a nurse. It's a deep intramuscular injection. I would find it, maybe if you were double jointed and very flexible, but even at that, libido has caused emboli, like fat emboli, because it's a very oily solution. All right, you have to be very careful how you give this. It has to be given deep intramuscularly. You have to withdraw, make sure you're not in a blood vessel, and you have to give it over, it should take about 2 minutes to give the injection slowly, and just observe the patient and make sure that you're safe. So it's not ideal. 4 mils is too much to actually inject into, generally we would, with Sustanon, it goes into the vastus lateralis, which is one of the largest muscles in the thigh. That's where you aim for it to go anyhow. So 4 mils is too much to self-inject. And if something happened, it can happen within minutes. So I would, advocate that, if it's only every 3 months or 4 months you have to have the injection, it's worth having it done safely and going to your GP practice and asking your practice nurse to do it, because practice nurses give injections all the time, and they're well used to doing it. So much better, definitely. Please don't do it yourself, whatever you do.
I've heard some women self-inject their decorative injection, which I find really tricky, because sometimes I go to my GP and some of the new nurses don't even know how to do it properly.
Yeah.
It's a very tricky one.
It's absolutely true. Excuse me, my dogs are going to go ballistic. I need to close the door. Hold on. They're going to go bananas in a minute. You'll hear them, even with the door closed. Look, go on out, the 2 of you. Out. Sorry, guys. I don't know if you've ever seen my two, but look. There's one of them.
Oh,
That's Riley. Ralphie, come here, because they're going to go absolutely bananas. Look at, I have two of them. Look, say hello, you two.
so cute.
Now I'm going to put you, I'm going to, yeah, see, she's starting already. Go on, out the door. Out. Thank you. Okay. Sorry for that distraction. Oh, God. My two kids have left home, so I have two dogs instead. Sorry, Nicole. What were we talking about then? Oh, the Decapeptyl.
Yeah.
Again, it's, it's 3 to 4 mil injection, and it has to be given into a deep muscle. So it's much better that you get a professional to do it. It's really difficult to self-inject. I prefer to, if I have to have blood tests, I'd almost prefer to take my own blood. I'm a bit funny about anyone else doing it. But to give a 4 mil injection, into your derriere, I think you have to be very brave. And I don't think it's safe to do it. It doesn't take long for someone else to do it for you. So, and if you're based in London, you could always tip to Trans Plus. You can organise to come into us in the clinic and have it. There are ways of doing it. So, stay safe, please. I had one. That's very interesting, Nicole, that you should say that. When I trained, and that was many years ago, we regularly gave intramuscular injections. Now, nurses, when they train, they do a lot more intravenous infusions and that. So, they aren't skilled and they're not taught. And oftentimes, if they're young nurses, they haven't got these skills. And I had one patient who was given an injection, and the injection wasn't given where it was meant to, and she ended up with problems and having to see a physiotherapist and have ultrasound treatments and different things for about 6 months afterwards. So anyone can get it wrong, so self-injecting is not a good idea.
So I just can read a question in the comments.
Yeah.
My nurse tends to give the libido jab quite fast. Can this affect the distribution of testosterone in the body?
No, it shouldn't affect the distribution of testosterone in the body. But, and I suppose, honestly, as nurses, when we give injections, we don't tend to hang around because there's always someone else waiting in the waiting room, especially if you're in general practice. But, it's better to give it slowly, honestly, because there are risks associated with it. And what I would say to you is, there's an excellent website by, I think it's Bayer PLC, who manufacture Libido. There's an excellent website, and on that website, they have recommendations for injecting and why and how you should do it. So you could always, if you find that your nurse is doing that, you could always, attach the link and just email it to the practice so that she can have a read, because it's not possibly like other injections that she would be giving. And there is the risk.
So another question is it possible to microdose testosterone until I have the desired changes?
Well, that's an interesting one. Everyone reacts differently to testosterone, okay? So it depends on what your desired changes are. But, even if you microdose on testosterone, your voice can still change. You can still grow hair in your face over a period of time. Your skin can still get oily and acne, So some patients would say to me, some of my non-binary transmasculine patients would say, look, Mary, I really like my voice to deepen, but I don't really want the hair growth all over my body and all the rest. But unfortunately, you can't choose, and we don't know how you're going to respond over a period of time. So we're happy to, support you in microdosing, but we don't know how your body's going to respond. So we can't guarantee you'll get one thing and not another, really.
Yeah, it's really hard, I think, because you can't really pick and choose what you want from hormones, and everyone's so different. So the thing that you might not want to have from hormones might be the first thing that you get. So that's really tricky.
Yeah, absolutely.
Would taking finasteride alongside testosterone slow down bottom growth?
That's an interesting question. And I mean, honestly, I don't think I have any patients taking finasteride alongside testosterone. Natal males will take finasteride if there's androgenic hair loss. They take 1 milligram a day of finasteride. But I don't know the answer to that question now on bottom growth, to be quite honest. And interestingly, we had a patient whom I brought to the consultant endocrinologist we work with last week, natal female with a testosterone level of 18.5, 19.4. We don't know where or from where she's actually producing the testosterone. And so she did have more bottom growth with T of her clitoris for sure, but I don't know the answer to that question, guys. That's something that I'd have to look up because I don't have any patients who are on it. And I stopped asking patients when they're coming back to me about bottom growth because I found they were a little bit probably embarrassed about it. And the last thing I'd want to do is make anyone feel uncomfortable. So, if someone has an issue or a problem, generally during the follow-up consultation, they'll bring it up. I've had a few patients who, because testosterone suppresses estrogen, and because they're having penile-vaginal intercourse, my trans male patients, sometimes they will get dryness of the vagina. So, we talk about that, the effect of low estrogen on female anatomy. And that's it. But I've not had anyone ask that question before. So it'd be interesting to look into it. I have had patients ask me about getting different creams. Is it DHEA creams, dehydroepiandrosterone creams, to apply to the area, try and stimulate growth. And I did contact the compounding pharmacy in London to see if they actually make any of the creams, or they could make any of the creams, but they don't. So I know there is something that you can get in the States, but quite honestly, unless I know something is manufactured safely, I wouldn't really recommend it, to be quite honest.
No problem. I will make a note of that question of who wrote it, and then.
Oh, for sure. Yeah, definitely. Because I love looking into, queries and questions. Because every time you do that, you learn something new. And, it's great. You have the answer then next time you need it.
So a question I just found in the comments is, can someone with sensory issues and difficulty taking a daily routine start on shots?
Yes, they can. And I would generally start them on Nebido rather than the Sustanon as well, and monitor and see how they go. Because we do have patients, who just wouldn't remember, to apply their gel every day. If you told me to do the same thing every day, I'm very doubtful, because my mind is always on so many bloody things. I'm very doubtful that I do it. I often say I don't even apply my hormone patch twice a week. But so I think I would find the only thing I do twice a day is brush my teeth. But so yeah, absolutely, we'll have that discussion without a doubt. And once they're stable and their moods are okay and they're not struggling in that sense, then yeah, it's definitely a conversation we can have. For sure. I'd never say no to anyone, who wanted anything. If you have a good argument for it and we can have a good discussion about it, and I know that you're going to be safe, then that's absolutely fine.
Another question is, how long does testicular atrophy usually last on HRT and T blockers?
How long does it last? Well, that's a good question, because the testicles do shrink. Okay, but they're very resilient because they lie outside the body, so it's lower than the body temperature. And I had a patient who had, and some of you guys might have heard this story before, but I had a trans female patient who had fertility preservation in the States and was on blockers and estrogen for 5 years. And she went back to get her sample, and it was gone. There was nothing. But luckily she hadn't had gender confirmation surgery. So we stopped all her treatment, and within 3 to 4 months, you know, she got a perfect specimen. And that was after being on estrogen and blockers for 5 years. So yes, the testicles will shrink, but, you know, if you stop, but again, you know, again, there are no guarantees that that would, you know, that would happen or that would work for anyone. But the body is very resilient, and it's amazing how quickly, under the influence of hormones, things can kick back into action. You know, they even reckon that the ovaries, even after 2 years on testosterone, and they're still doing research, you know. So we're learning more all the time.
Wow, that's so interesting. If a trans man has a total hysterectomy, leaving just testosterone jabs as the acting hormone in their body, will the lack of estrogen affect them? As I experienced joint aches and changes since.
Okay, well, that's interesting, because testosterone is meant to help your joints, to be quite honest, and strengthen. Yeah, because if you think testosterone stimulates the growth of muscles, so muscles are connected to your tendons, and muscle supports your joints. So in fact, it, you know, I found with some of my patients, it actually improves conditions like that they have. And also what I found interestingly is, and this goes both ways. Okay, so if you have a trans male who's had a hysterectomy, oophorectomy, so the ovaries are removed, the uterus is removed, and they end up with a normal male estrogen level. Okay, so it shouldn't really, in fairness. And also what I find is, with my trans female patients, when they have gender confirmation surgery, I'm always amazed. Their testosterone level returns to that of an assigned female at birth, you know? So it's not that you have no estrogen. You do, because cholesterol makes estrogen, okay? It's the precursor to all hormones. And other tissues in your body will produce estrogen as well, like even your fatty tissues, your adipose tissue, okay, produces estrogen. So you still produce estrogen. So you know, in fairness, you should be okay. Sometimes, again, as I said earlier, if you're having penile-vaginal intercourse, there can be some dryness in the vagina, and I would recommend the use of Ovestin cream 3 nights weekly for that, and it works very well.
Perfect. So there is a really interesting question about allergies, particular testosterone, I think, if it contains any coconut products, or just it'd be good to discuss just in general if, you know, allergies and hormones.
Yeah, well, the only one we really have to worry about is sustanon, because the base for sustanon is arachis oil, which is peanut oil. So if you're allergic to peanuts, then, you know, you'd have to avoid sustanon for sure. And also, if you're very allergic to soya, you should avoid sustanon. Okay. Nebido and Testogel are fine. I find some patients who have skin conditions with Testogel, you know, if they have eczema or they've psoriasis, to avoid applying the gel to those areas. But, you know, if you have open areas of skin, because it's an alcohol base, you really wouldn't want to be applying it to those areas. But otherwise, you know, they're the main things. And you'll always find people react differently to different to different medicines. But on the whole, I find that my trans male patients wouldn't have as many problems as my trans female patients would with the medication that they're taking.
So what about estrogen? You know, a different pills or different medications.
Yeah,
Do they have any interactions?
I would have, for anyone over the age of 40, we avoid oral estrogen, okay, because the increased risk of clotting, okay, because oral estrogen, it will affect your clotting factors. And of course, again, we advise all our patients not to smoke. So over the age of 40, we apply transdermal. So it's either a gel or it's a patch. And actually, a lot of our patients now prefer the transdermals, even our younger patients, you know, they really like Sandrina gel, which they apply twice a day, or, you know, we have a weekly patch or we have a twice weekly patch. So there are lots of different options. But I've only had one patient who we started on Sandrina gel, and we started them on 0.5 milligrams twice a day, 0.5 once a day, and then we had to reduce it to 0.5 every 2 days, and still couldn't tolerate it. Was getting headaches and feeling really poorly and unwell. And we tried a 25 microgram patch, still couldn't tolerate it. So, and really wanted to, you know, move on and progress. So we ended up applying literally not a patch, some gel just once a week to try and introduce it to it. So everyone will react differently. We never know how someone is going to react. So, you know, we always say to patients, look, if you have any concerns, any issues, any problem, you know, just email in, because every Wednesday, you know, we spend about 3 hours in a meeting going through patients' concerns, discussing them, blood results, discussing them. You know, it's a great place for the clinical team to learn. And also, you know, one of our admin always joins us so we can get back to the patients as quickly as possible. Having said that, sometimes, guys, it can be, I know it can be a little difficult getting through, but we have 2 lovely new admin who have joined us. Nicole, like not Nicole here, not the lovely Nicole here, but we have another Nicole. We seem to be doubling up on names in the clinic at the moment. And yeah, because we have 2 Lucys, we have 2 Nicoles, we have 2 Natalies. Oh, bloody hell. So if you're not named any of those, you won't get a job, obviously. But yeah, so Nicole has joined us, and also Andrea, lovely gentleman. So you might, if you're ringing into the hormones, you might get to meet those guys. You might see their names on emails or whatever. So yeah, we've got a few more staffing because we're getting busy and we want to be able to get back to you. But, you know, bear with us if you have any problems.
So we are going to be answering the last question for today, Mary, because I know that you have to go. What's the perfect through level of testosterone before a jab, or is it different to each person?
Okay, so it is different to each person for sure. Ideally, we're looking for the trough level between, say, 8 and 12, you know, but recently, probably, oh God, it could be about 6 weeks ago now, the British Association of Gender Identity Specialists had their annual meeting, and this time it was online. And it was the lovely endocrinologist, Dr. Carl Neff from Dublin, who spoke. And interestingly, what Carl said is, you know, they always say to the patients, no, how are you feeling? How do you feel, you know, before you have your injection? How are you feeling on? And if the patients are transitioning or they're doing well, it's not always about the levels. You know, don't focus on the levels. And I tend to try, you know, I like to see what's happening. But I don't think you focus solely on the levels. I mean, patients are transitioning, you know, and they're changing, because not all natal men will have the same level of testosterone. They don't need the same level of testosterone, you know. So it's about how you're feeling. If you're not feeling good and your level's a wee bit low, well then yes, it can be adjusted, and that might help for sure.
Perfect. So I can see some other questions, but if you just leave us a message, then I can get back to you with the answer. So
listen, guys, it's been lovely to see you all. Thank you so much, Nicole.
Thank you so much for joining.
Have a lovely week. How much I'm reading the questions now. I need to go. I'm off one like that. I say I have to go, and then I'm like rushing at the last minute. Okay, listen, guys, have a wonderful weekend. And sorry it's so brief, but you know, if you have any questions, as you say, you can just send them in to Nicole and she'll get back to you. Okay. All right, guys.
Bye, Mary.
Bye.